window. So I will only talk about two important calculations which are essential in this. So the first one, both these calculations are important to help prolong the life of the filter. A normal CRRT filter can last up to 72 hours or up to around 770 liters of blood filter. Up to filtering around 700 to 770 liters of blood. So there is something called filtration fraction, which helps us in ensuring that we prolong the filter life, because the filter has around 150 ml of blood in it. So if the filter clots, that 150 ml would be lost. And for a critically unwell patient, that is a large amount of blood. So we calculate something called filtration fraction, which is the amount of plasma that gets filtered. So how is that calculated? Normally, I said in a CRRT machine, we set the blood flow rates around 100 ml per minute. And the plasma is around 70% of blood, right? So plasma flow rate will be around 70 ml per minute. The dialysate flow rate normally we set at around 1000 ml or 1 liter per hour. Roughly, a 5-liter dialysate bag will last for 5 hours at this rate. So, which will come up to 17 ml per minute. The filtration fraction is dialysate flow rate divided by the plasma flow rate expressed as a percentage. That will be 17 divided by 70 expressed as a percentage. So here it comes as 24%. If the filtration fraction is greater than 25%, then the filter life will get shortened. So we have to ensure that we adjust the blood flow rate and the dialysate flow rate in certain way so that the filtration fraction is maintained. There is something called transmembrane pressure. As I said, some of the filters have the capability of adsorption, where they adsorb to these solute molecules. So this increases the pressure of the semi-permeable membrane. If the transmembrane pressure is greater than 200, then it is an indication to replace the filter. And I would also like to talk about potassium replacement, because it is one of the very important aspects. Whenever somebody is dialyzed for hyperkalemia, it is a human tendency, if they have a potassium of 6.5 or 7, so it is human tendency to believe that we just need to use filtrate on dialysate bags which have no potassium, because patient already has a serum potassium of greater than 6. But that is not how it works. As I said, in diffusion, there will be equilibrium established between the dialysate fluid and the patient's blood. So when that is established, if the dialysate fluid has 0 potassium, then the potassium from the patient will enter the dialysate fluid to achieve an equilibrium. So if the patient's potassium is 6 and dialysate has 0, at the end of the bag, it will be equilibrated to 3. And if you run another bag with no potassium, then you have chances of getting the patient's potassium down to less than 1.52. So this can cause serious arrhythmias and cardiac arrest in ICU. So we have to be extremely careful when we run naked bags, is what they say, without potassium, dialysate bags without potassium. And it has to be for a very small limited amount of time in order to ensure that we don't cause serious electrolyte disturbances. So how do you calculate the amount of potassium? As I said, these bags are all 5-liter bags. So if you add 20 millimoles to 5 liter, each liter will have 4 millimoles. And if the patient has 6 millimoles per liter, when it equilibrates, it might come down to 5 millimoles. So that is how. So if you want to run a bag with low potassium, use at least 10 millimoles. That will be 2 millimoles per liter. So that is one thing that we need to calculate. The another important thing is anticoagulant dose. So as I said, citrate and heparin are both anticoagulants used in CRRT. Citrate is contraindicated in patients who have liver dysfunction because citrate is metabolized in the liver. Now, the normal dose of citrate that is used is around 3 millimoles. But then if the patient has bleeding tendency, you can reduce it to 2 millimoles. Or if you think patient has liver dysfunction, then you can put them on heparin. Heparin dose is titrated with a target APTT of 45 to 60 seconds. So that is another thing that you need to calculate. And flow rates, as I said, there was some theory that if you increase the dialysate flow rate, then obviously the patient will have faster removal of toxic solutes and recover faster. Unfortunately, that is not what happened. There was much more severe electrolyte disturbances, which caused more severe complications than what was anticipated. Thus, increasing the flow rates is most often not the solution for faster dialysis. Now, let us move on to the controversies, because this is something that is my forte. It involves research questions and looking at evidence and synthesizing what is the recommendation that is currently available as of November 2024. So there are several guidelines which have come up with regards to dialysis. The most common ones that are currently recommended are the Kidney Disease Improving Global Outcomes, or KDIGO guidelines. There are also NICE guidelines, SCCM guidelines, UK Kidney Association guidelines, which are all dependent on the geographical location of the center. But one thing which is worldwide accepted is the KDIGO guidelines, which were released in 2012 and updated last year. So nothing much changed with the update. I will talk about the current guidelines. So before we move to the guidelines, there are two important things that I'm sorry, I'll just move the screen to a corner. Sorry, just give me 1 second. There are two important criteria which we all need to know when it comes to knowing about the current evidence, because what happens is most patients who are recruited into trials are recruited based on the amount of renal dysfunction that they have. So the commonest criteria that are used whenever patients are randomized are rifle criteria and the Akiki criteria. I will talk about that in the next slide. So in rifle criteria, I want you to focus on the stage of failure. That is when dialysis will come into picture, and that is usually termed as an increase in serum creatinine more than 3 times the baseline. And we will not talk about loss and end-stage kidney disease, because that does not fall into the ICU setup where loss of kidney function is more than 4 weeks. And then this is the KDIGO AKI guidelines staging. And in this also, stage 3 is where most patients will require dialysis, where creatinine is 3 times the baseline. And this is where most patients are recruited. So when should we initiate renal replacement therapy? So the Akiki, or artificial kidney initiation in kidney injury trial, it was first published in the year 2016 in NEJM, where they compared dialyzing a patient within 6 hours of recognizing AKI, or acute kidney injury, versus waiting until standard indications. What are the common standard indications? Fluid overload, hemodynamic, not hemodynamic instability, fluid overload, and then hyperkalemia requiring dialysis, toxins requiring dialysis, and severe refractory acidosis. These are the 4 common acute indications for dialysis. So they waited for any of these 4 acute indications to develop versus less than 6 hours of onset of AKI. And they did a multi-center trial and looked at 60-day mortality in France, and there was no difference in mortality between the two. This was followed by Elaine trial, which was again published in the year 2016 in JAMA. Here, they compared dialyzing within 8 hours of the onset of 8 hours of randomization versus delayed, where they waited for 72 hours. And here also, they recruited patients who were in stage 3 or 2 KDIGO staging, like we saw in the last slide, and they noticed a trend towards reduced 90-day mortality in their post hoc analysis. Then came the ideal ICU trial in the year 2018 by NEJM because there was a slight trend towards improved mortality. So ideal ICU trial was carried out where they compared late, they waited for 12 hours versus later, which is 48 hours, and they included rifle stage failure and they looked at early cessation because this trial had to be ceased early because they did not find any difference in mortality and there was some inclination towards harm. So they decided to cease the trial early. The most important trial on the timing of renal replacement therapy was the START AKI trial. This was published in the year 2020 in NEJM, where they compared standard indications, those 4 indications, versus accelerated dialysis, where they dialyzed patients within less than 12 hours of randomization. This was a massive trial looking at 3,000 patients across 168 sites in 15 countries and found no difference in mortality. Then finally, in the year 2021, Akiki 2 in France, it was published in Lancet. They compared delayed versus very delayed mandatory indication for dialysis. Delayed is waiting for 72 hours since the onset of AKI versus very delayed, wherein only 4 refractory fluid overload, refractory acidosis, refractory hyperkalemia causing ECG changes, and toxins were the 4 mandatory indications. And then they also found no benefit of waiting for very delayed, but there was also a risk of what do you say? If the AKI is not improving in 72 hours, if you delay it further, the risk of end organ damage and long stage renal failure in the future, all of that increased. So there was no benefit of waiting until if the AKI is not improving, basically. So finally, a systematic review was conducted, which showed no difference in outcomes with waiting. Okay. So what is the final recommendation? There is no benefit of early dialysis for sure. So if AKI sets in, no benefit of dialyzing within 6 hours or 12 hours. But important to ensure that balance indications with clinical scenarios. So if the patient is well, if there is improvement, there is also something called furosemide stress test, wherein you can give a test dose of furosemide and see if the renal function improves. So you have to balance the indications for dialysis with the clinical scenario of the patient and do what is best as a cohesive shared decision. So refractory acidosis for pH less than 7.1, which is not improving with fluid resuscitation, refractory hyperkalemia causing ECG changes, not improving with medical management, toxins, fluid management, severe pulmonary edema causing hypoxic respiratory failure. And then you have to also balance the demand and capacity. So it's more like whether the patient has a greater demand for producing more urine for whatever reason, and then whether the kidneys have the capacity to produce that. So look at the demand capacity imbalance before you initiate renal replacement therapy. And please do not use isolated biomarkers like creatinine, urea, or because it is stage 3, you have to dialyze the patient. There is no evidence for that. So as of now, this is the recommendation. And involve the home team whenever you are starting dialysis. It is not a benign procedure, and counsel the family as well. So which technique to choose? CRRT versus IHD? I think it depends on the appropriateness and availability of resources, including the nursing resources. And because it is, as I said, it's not a benign procedure. It involves changing the bags every 4 hours. You need a dedicated nurse. It involves a lot of hemodynamic monitoring that needs to be done. So all of this is important. And this also helps in determining whether CRRT is better for your setup or an IHD is better. And look at the hemodynamic stability of the patient. Hemodynamically unstable patients, it is better to go for CRRT if available. In raised ICP, And acute kidney injury patients, CRRT again is better because it doesn't cause rapid electrolyte shifts, sodium changes, etc. And then the site also, there is a recommendation where they say right IJV should be preferred first, then followed by femoral, then left IJV and subclavian. And for patients on ECMO, CRRT definitely can be done, and ensuring that you maintain the hemodynamic stability along by ensuring perfusion pressures are maintained is very important. So Cochrane meta-analysis in the year 2007, and then followed by guidelines by Nash et al. In 2017. All of this recommends CRRT in patients who cannot tolerate large fluid shifts, and not to use isolated biomarkers or staging, and go for shared decision making. And there is no long-term benefit of CRRT versus IHD, either of the renal replacement therapies. The long-term incidence of chronic renal failure in these patients is about 25%. So it doesn't matter whether it was CRRT or IHD, whatever was used. So what dose? The goals of electrolyte, acid base, and the solutes and fluid balance are what determines the dose of CRRT or dose of CRRT that you use. So, and this is dose calculation for IHD and peritoneal dialysis. We will not touch that. But for CRRT, we usually say that an effluent volume of around 20 to 25 ml per kg per hour at least should be targeted for efficient clearance of solutes. Which anticoagulation? Citrate, unless contraindicated like in liver failure, or you can use heparin only in the circuit if the patient is bleeding, or systemic heparin targeting a APTT of 45 to 60. And we always give calcium reversal whenever citrate anticoagulation is used. So there is some studies, a lot of studies and data looking at antibiotic filters, charcoal filters. All of these employ the principle of heme adsorption, where you know how we do plasma exchange for patients, autoimmune disease patients, SLE, all of those patients. So there, large globulins, large molecules also can get filtered. So CRRT using different types of filters is an option wherein large molecules will not be filtered and does not cause serious issues for the patient. So here hemadsorption is the principle where the filter is coated with certain substances that can adsorb onto certain substances. So this was principally tried in sepsis patients to adsorb the endotoxins. So there came cytosorb filters, Jaffron filters, Toramixin cartridges, polymixin filters. So all of these cartridges, there have been a lot of trials which are going on looking at this. The trials that I would like to emphasize are UFAS, which was published in JAMA in 2018, and UFRATES, which was published in Intensive Care Medicine in 2018. And the current trial, which is ongoing, is the Tigris trial, which has looked at 150, which is looking at 150 patients. As of 4th November, they have recruited 135 patients, and they are comparing polymyxin filters with normal filters and looking at mortality outcomes in sepsis patients. So keep an eye on this Tigris trial because they have also included patients from Euphrates in this trial. So I think the results will be interesting. There were several trials which looked at cytosorb filters. So far there have been 6 RCTs in the last 6 years, and they're all small size RCTs. They've also done in COVID patients and infective endocarditis patients, but they have not shown any mortality benefit. So no mortality benefit, some evidence of harm with ECMO patients with these filters, and definitely there are more RCTs necessary. So special situations, as I said, in ECMO, patients are very sensitive to fluid movements. So just careful hemodialysis is still possible, and ensure that you are having proper anticoagulation, targeting proper APTTs whenever you're using in ECMO patients. And in post-transplant ICU patients, especially liver transplant patients, if they go into AKI, they have poor prognosis. So just though renal replacement therapy is associated with poor prognosis, it is reasonable to start them on renal replacement therapy if they need to be. With regards to poisoning, again, you cannot do large RCTs when poisoning patients because of recruitment issues. So there is no evidence, but there is no evidence of harm either. So we are still using dialysis for those patients who present with dialysable toxin poisoning. In pregnancy AKI is a different topic, but there have been studies which have safely utilized CRRT in pregnant patients presenting with AKI. So PRAKI is another trial that you can go through. In children, again, pediatric dialysis is a completely large topic on its own, and it is impossible to cover this in just a one talk. So maybe we will have another talk on that. In developing countries, is PD an option? Definitely, yes. If the patient can withstand peritoneal dialysis and the complications, I mean, complications in the sense because the fluid is left in the abdomen, it can cause a respiratory compromise, basal atelectasis. If all of that is properly taken care of, definitely peritoneal dialysis can be utilized as an option. So starting dialysis is one topic, but when to stop dialysis is equally important. Dialysis should be stopped the minute it is no longer required. Kidney function has recovered, especially look for eGFR and proteinuria. Proteinuria, persistent proteinuria is a sign of probability of a chronic renal failure that is impending. And ensure there are shared goals of care. A patient who is not for resuscitation should probably not be for dialysis as well. So discuss with the family and the home team. So CRRT to IHD in ICU patients, whenever when the patient comes off vasopressor support, when the intracranial pressures are stable, or if there are no ongoing clinical indications, try and see if you can move them to intermittent hemodialysis. So in conclusion, there is no benefit of early CRRT. Shared decision making is very important. Renal replacement therapy isn't a benign process. Family counseling and the long-term implications should be discussed. Monitoring is indispensable, be it electrolyte monitoring or hemodynamic monitoring. And please do not start dialysis based on isolated biomarkers. So I have referenced a lot of journal articles, so you can DM me for the list. And these are the acknowledgements. And you might have noticed why I have used green all through my presentation, because green is the color which the Kidney Foundation recommends to bring awareness about kidney disease. Thank you very much. All right, I will end this meeting. I hope this presentation is useful. And if you have any doubts, you can please put it as a comment and I will respond. Thank you.